Hey, coming to you with a wrap up of the Heart Failure Association of ESC. I'm joined by my great colleagues here, Harriette Van Spall. Welcome, Harriet.
Thank you for having me, Mike.
Jim Januzzi. Welcome, Jim.
Hey, Mike, how are you?
And Javed Butler. So, Jim, let's kick off with you. Talk to us about the acute heart failure studies that were presented, some of the take home messages. And you had a late breaker there.
Yeah, I did. And, this meeting was really quite remarkable. More than 5,000 people attended. And, from the beginning to the end, it was just full of incredibly good science, including trials on chronic heart failure, actually, which is what I spoke on, with early phase, middle phase, and later phase studies. I presented in a really remarkable session of late-breaking clinical trials that featured really something for everyone. There was a phase 1 study looking at a monoclonal antibody against transthyretin amyloidosis. All of the therapies that we're giving for transthyretin are about shutting off the gene or silencing it, but this therapy actually purports to remove amyloid from the tissues. And this monoclonal antibody was well tolerated in patients with transthyretin cardiac amyloid, reduced extracellular volume, improved scintigraphy, and also reduced biomarker concentration. So really exciting to think that we might have this sort of joint approach of silencing or interrupting plus removal.
It gets back to the idea of you're going to turn off the sink or mop up the floor. We seem to be turning off the sink, but this is mopping up the floor. Jim, you seem to indicate that maybe there's regression. Is that true? I mean,
that's actually what they demonstrated, which is mind-blowing, because we had hoped with silencing or interruption, we're looking at, for example, CRISPR therapies to reduce transthyretin or block it. This actually suggests that it's possible to remove it from the tissues. And what's really interesting in this study is that patients treated with the antibody had an exacerbation of their orthopedic discomfort from amyloid, suggesting that the active process of removing the protein led to those symptoms, almost a marker of target engagement.
Wow, that's amazing. What else was up?
Yeah, so in that session, we also had a phase 1 study of a novel therapy that's based on a compound called neuregulin. This is a drug that's also known as JK07 that was looked at in patients with heart failure. And the interesting thing about this drug, we know that neuregulins can promote reverse cardiac remodeling and improve symptoms. The problem with neuregulin in the past was off-target side effects, including gastrointestinal side effects in particular. This drug is actually a chimeric monoclonal antibody that both stimulates like a neuregulin, but also blocks a receptor called ERB4, which is responsible for many of the side effects. So a more well-tolerated version of the drug without the off-target side effects. And what they were able to show was significant reverse cardiac remodeling, even in a very small number of study participants.
Great. And Harriet, what happened in the way of monitoring, PA monitoring?
Right. One of the trials that really made the news was the Monitor HF trial. It was an open label randomized trial, multi-center in the Netherlands. Patients had chronic heart failure, NYHA class 3 symptoms, and a previous heart failure hospitalization. The trial tested the efficacy of hemodynamic monitoring in the form of CardioMEMS among patients who qualified for the intervention. They were seen by clinicians at 3 and 6 months, and then every 6 months thereafter. And the intervention was able to improve the primary endpoint of the mean difference in the KCCQE composite score at the end of the trial period by 7 points. So well above the threshold of the clinically minimally important difference. And it did so because it was able to facilitate more titration of therapies, and in particular diuretic therapies, thereby allowing patients to feel better and function better. One of the secondary endpoints was heart failure hospitalizations, which, as you know, burdens healthcare systems across the world. And this intervention was able to reduce heart failure hospitalizations. Didn't move the needle on death, but there's been 2 other trials, Champion, which was a large outcomes trial that showed a reduction in clinical endpoints, And then the guide HF trial that was more neutral. I mean, it had some barriers during the COVID pandemic, but I think on the background of these two trials, Monitor HF expands the evidence by including a European setting and also includes important health status as an endpoint that I think adds to the breadth of evidence.
Great. And Jim, what about Tracer? That got a lot of attention.
Yeah, thank you. So, so the Tracer HF study was a trial that we did at the Baim Institute. Thanks for bringing it up, Mike. And it did actually get some attention. It was listed in the top 10 studies that they featured at the end of the meeting. So we were really excited about that. This was a phase 2 study looking at a novel drug, a chaperone for copper, actually, because copper depletion intracellularly can lead to myocardial dysfunction and remodeling. So we looked at, in an ascending dose fashion, the use of this compound called trientine to treat patients with chronic heart failure, promoting reverse cardiac remodeling, improving 6-minute walk distance, improving Kansas City Cardiomyopathy Questionnaire, and also lowering NT-proBNP at both 4 and 8 weeks after treatment. So we're pretty bullish about this now.
It's great. And you're thinking about phase 3, beginning to plan a bit?
Yeah, we're starting to have discussions already, Mike. We're sketching out phase 3 designs and discussing how we're going to move forwards. We feel like we have a dose. It looks like the 300 milligram twice daily dose is where we're going to go.
Well, thanks for making Bain proud. And Harriette, you also had a late-breaking presentation.
I was really excited to present the 3-year outcomes of the PACT-HF trial. This was a pragmatic implementation trial that was difficult to execute, but that delivered evidence-informed services to patients who were discharged following hospitalization for heart failure. We randomized 10 hospitals in Canada to the intervention, which included nurse-led inpatient education, a care plan for patients with heart failure, and then nurse-led home visits for weeks following discharge, and heart function clinic visits that were multidisciplinary and that were initiated within a month of discharge and that continued indefinitely. The goal was for care to be optimized according to guideline recommendations that we shared with all of the clinicians at the onset of the intervention period. Among the 2,494 patients who were enrolled, unfortunately, we found that the intervention did not improve the primary composite endpoint of all-cause death, rehospitalization, or emergency department visits at 3 years following discharge. And this applied to either the intention to treat analysis, which was the primary analysis, or the on-treatment analysis that we did to account for infidelity to the intervention or crossovers that may have been unintended. We found, however, that after accounting for death as a competing risk, there was a small reduction in heart failure hospitalizations, but this was a secondary endpoint and should be considered exploratory or hypothesis generating. Of course, all-cause endpoints are difficult to move the needle on with any intervention, and in particular, our health service intervention, because on the background, we see variations in practices and in healthcare services that are offered across jurisdiction. I should also say that we found no difference in the uptake of guideline-directed medical therapy across all of the classes of medications, with the exception of ARNIs. We found about a doubling in the uptake of ARNIs with the intervention, but the overall utilization of ARNIs was very low, about 1.5% in the usual care group. So not enough changes in therapies to really improve outcomes in a substantial way. So when we create these services with the assumptions that they will improve outcomes that are clinically relevant to patients, we need to turn to the evidence, and that's where implementation trials come in. And I was happy to have this trial spotlighted at the wrap-up session today.